April really isn't like that. Oh, hey, we're live. Hey, everybody.
Hey,
How's it going? Happy New Year, everybody. So today is Sunday, January 3rd, 2016. It is 10 p.m. Eastern Time, or as we refer to it, SPSM time. And do not adjust your computer screen. That's right. I am not Dr. April Foreman. Of course, I wish I was. We all wish we were. I'm Dr. Mike Savilla, and flying a co-pilot with me tonight is Dr. Bart Andrews. Bart, how you doing tonight there, buddy?
hey, doing great, Micah. What a treat to be here. It's my first blab. My blab cherry has been probed, not officially popped.
That's right. So before we start, I have a statement from our lawyers that we have to say. The views expressed on this show are not necessarily those of SPSM or even me or Bart Andrews. Viewer discretion is advised. So we are stealing SPSM time slot tonight. We are either a mid-season replacement or we're like a bad spin-off show. What do you think there, Bart?
Yeah, I like spinoff. I think spinoff is great.
We're like SPSM Minions. What do you think?
Minions. I was thinking more of what was that after Happy Days? There was Joni Loves Chachi. You remember that?
Exactly. Yeah.
So
yeah.
We're kind of like the Joni Loves Chachi.
Yeah, that's right. Yeah. We're not Bay Night. We're Baywatch. We're like Baywatch Nights.
Yeah, Baywatch Nights. I don't think we've got the breasts for it, but I think that with time we could work on it.
No, we're not MASH. We're like After MASH.
After MASH, Trapper John.
Oh man,
it was a good show. Did you like that? I loved that show when I was a kid.
Yeah. So what are we doing this? Well, our good friend April, who's with us and who we may let chat later. Previously on SPSM, she said, "Hey, go outside the box and do something for SPSM." And I, contacted Bart and say, "Hey, we should try this blab thing." And that's where we're at. So Bart, this is your first day on Blab. Chatting, experiencing the whole thing. What do you think of the Blab platform here, buddy?
Okay, I'm gonna having messed around with Hangouts for the last year. This seems much simpler and cleaner. And it just seemed it works really easy. It was easy to get on, no challenges. And I like that the Twitter is built in. You can tweet. I love when you tweet. You got the GIF built right in there. That's very cool. And then you've got a chat function. So I like all the bells and whistles, and it seems like it's working really well. I mean, I haven't used it before. We just got right on and we were there just like that.
And shout out to all 15 people who are watching me live. I think we're already trending on Blab. I don't even know that, but I'm making that up right now because we're bringing it here to the Blab, and for people who are watching live, they can give us a little thumbs up or little claps or whatever those are called, props. And I already got a question on how I got my little name thing here. And for people on Macs, it's called Cam Twist. You download that and you can put any kind of graphics that you want on that. I got that from a little blab people here. But yeah, having a good time. And Bart, I do like the real time chat room that we have. People who are making fun of us right now. I know you're responding to some of them, and I'm ignoring them. But what are you going to do?
It's good stuff. It's a little distracting because there's some funny stuff going on.
That's right.
And I love the hat. That's adorable.
Thank you. How's Mr. Frog? Mr. Frog's behind your shoulder there, and
Oh, so I should have brought my Wookiee. One of my best Christmas presents for the year was a Wookiee backpack, a Chewbacca backpack. And it turns out the Chewbacca Chewbacca backpack was actually designed apparently for a very small 8-year-old. But that's okay because I did take the Chewbacca backpack with me to see Star Wars, and Chewbacca sat on my lap for the entire viewing, which was, we could cuddle, and at times when Chewie would do things, I would hold up it was really exciting. I should have brought Chewie in with me. I didn't. Yeah.
There's cuddling, really?
Yeah, well, it's a Wookiee, and it's pretty cute. Pretty cute Wookiee.
Yeah. Got nothing. I don't know. So did you see the movie? Did you see the movie?
The movie was awesome. We took my mom and my mother-in-law. The kids went. My daughter refuses. My daughter is on an anti-Star Wars campaign. She hates it, and she wouldn't go. So we didn't take her because obviously she wasn't going to go anyway. And I don't get it, but there's a real strong anti-Star Wars thing out there. She's part of the Star Wars hater group. You don't get to pick your kids, they tell me. Apparently, that's I got a word for that.
So the 15 people in here, we are going to talk about some good stuff. We're going to talk about primary care. We're going to talk about mental health. We are going to talk about suicide prevention. But this is just we're just kind of just getting just easing into things here, kids. Easing into things. And so people ask me about my little scrolly thing here where I have my name and. That is if you're on Macs, the app or the program is called CamTwist. You download
cool.
that, and because after the program here, they won't have our little names up here on the YouTube replay. But they will have that little thing down there.
Oh, that's cool.
So yeah. So that is that is what that is about. And people are already using the question function in the live chat room there. So I believe it is /Q, and you'll be able to ask us some questions and or make fun of us. We appreciate all your feedback. All hate mail goes to @DocForeman on Twitter.
Her turnaround time on email is a little slow, so if you have hate mail for her and you don't get a response right away, it's okay. It's in spam or she's working on it. Don't panic.
So anything else about your holidays there? You did some TV. You did some binge watching over the holidays here. What was that about?
We binged on Curb Your Enthusiasm, watched all 8 seasons in the span of about we did a season a day, and I have to say that that show was awesome. And I was really sad when we watched the last episode this afternoon because Larry David is incredibly talented, and some of the setups that they put people in was really interesting. So yeah, not a little. If you don't like that kind of humor, I could see it not being an enjoyable experience because Larry and his buddy Jeff have some challenges in terms of social appropriateness and morals. But yeah, aside from that, really funny. Have you seen the show, Mike?
No, I have not. I've seen some of it on YouTube. And I have not partaken of it. But before we go into this, every week on SPSM, I make remarks about Bart's hair. So Bart, let me ask you. So do you use product in your hair? Do you use gel? What's the secret to it?
No, and I want to be clear because there's a lot of confusion about what's a product and what's a hair repair or hair care, hair healing. Medicine, for instance. So I don't use any product in my hair. I do use a leave-in conditioner for dry and damaged hair, but that's not a product. And if Shy's paying attention, it's not a product. And I've stopped getting haircuts. I believe that haircuts are basically a bit of a scam, kind of a pyramid scheme. You have to going back. It just goes nowhere. And so my last haircut actually was in August of 2015, and we'll see how long I can ride this out.
Wow. Huh.
Yeah.
Huh. Okay. So, is it true you're actually blonde and you actually color your hair? Can you confirm that?
That I color my hair? No, I don't. I've thought about it. Particularly the white in the beard. When the beard came in white, that was really that was a hard moment for me because all of a sudden you can act like you're younger, but when you have gray in your facial hair, it's hard to act like you're not old. So. Yeah, so but no, this is my real color, the kind of, I don't know what you'd call it, dirty brown, dishwater brown. I like dishwater brown.
Oh, I like dirty brown. It makes you look
dirty
like a bad
brown.
boy.
I got dirty.
Bad boy.
Dirty brown here. And then kind of a red pepper, salt and red pepper beard, maybe. I don't know.
Nice. Yeah, see, people are liking that. People are liking the hair, so.
They are, and I'm wearing compression pants. I don't know if that's but I'm a big fan of compression.
Oh, and I'm not wearing pants, so I don't know.
Yeah, you don't need pants when you're doing these kinds of shows.
That's right. Yeah, it's like Anchorman. I don't know.
Free balling is underrated, and I think if more of us would, and I also want to point this out. It's really hard to fight a war without pants. So if we had kind of a global no pants I think a lot of peace would break out, Mike. I really do.
World peace is breaking out everywhere.
So, yeah.
That's right. You know, my hands are right here. Hands are right here. Right here. You dirty people out there. All right. So let's change gears here a little bit. So the other reason I want to talk to Bart is that every time every week I'm see Bart on screen there. I read the bio. I read, the Twitter description, and maybe I dismiss the show about, what do you do and what your job is, and how are you all connected to all this SPSM crowd? Let me start out just kind of reintroducing yourself and just talk about, what you do and how you got connected with this SPSM thing in the first place.
Yeah, well, thanks, Mike. I'm really very new to social media. In fact, I've been on social media officially a year and 3 months. Probably like September of 2014 is when I first got on Twitter because my boss said get on Twitter. I had tried to get on Twitter a few years before that, and it was didn't go anywhere. I didn't know what I was doing. And I just didn't know anything about social media. And so I'll tell you my social media story at first. I got on Twitter in the fall of 2014. And then I'm the president of the National Association of Crisis Organization Directors.
What?
What is that? Yeah, I know. It's a lot of people don't know that.
Yeah. What does that mean? I don't even know what that means.
So it's a great NASCAD. We go by NASCAD. Is a great organization. Crisis lines. There's hundreds of crisis lines across the country. But unlike hospitals or primary care clinics, you usually have a lot of local crisis lines, right? St. Louis, we have 2 crisis lines. The state of Missouri actually has like 3 crisis lines in the entire state. So it's really hard to develop a social network of folks that kind of know what your life is like. And so NASCAD is an organization where directors, managers, supervisors at crisis organizations have a way to connect, have peer support advocacy. The organization has been around for quite a while. I've been a part of it since 2009 and just absolutely love the folks. And I met April, the amazing Doc Foreman, and Tony Wood at the 2014 NASCAD conference in Nashville. And that's where I found SPSM. I had no idea what suicide prevention social media was. I didn't even really think you could use social media for suicide prevention activities. Tony, April. They're amazing. They're talented. They're infectious. And so they're like the gangrene of social media. Once you get it, you start smelling like almonds, and you're on social media a lot. Yeah, that was a stretch, Mike. I apologize.
Almonds, as opposed to like cashews, or
I'm thinking almonds. Doesn't gangrene smell like almonds? I read that one.
I don't know. I'm not wearing pants, so I have no idea.
Yeah. So anyway, I fell in love with Twitter, and being a part of the SPSM chat was really a life-altering experience because I love Twitter. I've learned so much, and I think one of the cool things about social media that I've loved the most is it's a place where people can connect, and they connect across all kinds of different groups. I've had more contact with people with lived experience of suicide, people with lived experience of mental illness, and have learned from them and their advocacy efforts, and being able to connect with other providers outside of the normal context of our jobs and structures has been absolutely amazing. So, like, if you've ever done BPD chat, those are just amazing experiences. So I've kind of fallen in love with social media the last year and a half. I work at an amazing organization called Behavioral Health Response. We're a crisis agency in St. Louis, Missouri. We originally started as the crisis line for the eastern region of Missouri, and now we've expanded in all kinds of other areas. My role there, I've done everything. I started as a phone clinician right out of my doctoral internships. I started working on the phones, evenings and weekends, mobile outreach. And I've just gradually kind of insinuated myself in every nook and cranny of that place. And over time, I became the vice president of clinical practice and evaluation. So that's what I do now. My primary focus is looking at our clinical practices, looking at best practices, and making sure that our clinicians are using the best techniques and skills available. Wow. And overseeing we're involved in a lot of research practice and research projects with suicide prevention and follow-up. And so those are things that I'm involved in as well.
So did that go all the way back to like even high school and college? You were interested in this type of topic or related topics? And
no. I was definitely a late bloomer. College, I really didn't know what I wanted to do. The first class that I actually got a decent grade in was Introduction to Psychology. That would have been probably 1990, fall of 1990. My first 2 years of college, I probably had amassed 6 credits from 4 semesters of college work. So the first class that I fell in love with was instructional psychology, and since at that time I was early in my own recovery from alcohol and substance use, psychology was something I just kind of really gravitated to. I really liked it. I went into clinical psychology, the Southern Illinois University Carbondale's clinical psych, their experimental clinical psych program. Loved it there. Amazing training program. But if you would have told me when I went into clinical psych in '93 that I was going to work at a crisis hotline 22 years later, I would have, I don't know what I would have laughed or cried hysterically, or a little bit of both. I think one of the things that happened is that when I started working at BHR, it was a crisis. Interestingly enough, I was at a crisis moment in my life for a lot of different reasons, and ended up working on a crisis line. Now, I'm not advocating that people who are experiencing a life crisis should work on a crisis line, but in my case, it worked out pretty well. And I think one of the things that happened in crisis intervention work, Mike, that was really powerful is that I realized in a clinic, there's many folks with a mental health that are fighting mental health needs that never make it into the office, that never make it to the hospital. There's so many barriers to care that we don't appreciate and don't exist often for medical care. And when I started taking phone calls every single day, right from the get-go, I was talking to people who were having thoughts of suicide. And I had done a lot of clinical work before I worked at BHR. And I worked with people at risk of suicide, but not that many. And it became very clear to me, one, how intense the need was, how many folks out there were fighting thoughts of suicide. It's a lot. And I also learned that the training that mental health professionals get around assessing intervening with suicide is atrocious and really unacceptable, to be quite honest. And so that was a real experience for me. I fell in love with the phone work. I fell in love with working with law enforcement, doing mobile outreach, being there 24/7, regardless of insurance, ability to pay, whatever, we could help people. That was very powerful to me. It's still very powerful to me.
How long were you in clinical practice for?
So I was, BHR was my first job out of graduate school, actually. So all of my clinical work was graduate school related. Started working in the clinic my first semester, started seeing clients, worked at the VA hospital at Marion, had a practicum and then a paid internship there. And then my doctoral internship was at a community mental health center in Tennessee.
Wow. Huh.
Yeah.
And then at some point you were like, oh, I want to do more. I want to get, involved organizationally, maybe doing some policy work and research at some point, and you felt like you'd be able to help more people doing that type of work.
No, it was a complete, Mike. It was a complete accident that I ended up at BHR. Actually, the way it happened was the summer that my doctoral internship was ending. My life was kind of going nowhere in a really, really quick way. And my wife sat me down at the table. We had a family meeting. Mike. We'd never had a family meeting before. And my wife said she's a kindergarten teacher, but she should have been an attorney. And she took me through a series of very intense questions. She asked me questions like, "So, what have you done in your dissertation?" Which was nothing. She asked
wow.
She asked what my plans were. What was I looking at in terms of postdocs or post internship experiences? And I said I had looked at some neuropsych placements in Miami. There were some cool behavioral medicine placements in San Diego. I wanted to go someplace warm. That's what I was thinking. Just someplace warm, sunny, nice. She said, "Have you filled out any paperwork? Have you called them?" No, I hadn't really done any of that. She said, "Yeah, okay." She said, "Well, let me tell you what I'm doing." She said, "I've got a house, and I've taken my job back." My wife had given up her job to follow me around for graduate school and internship. She said, I've got a house, I've got a job. And I was like, "Well, that's fantastic." and then, yeah, I know. And then she said, "And if you want to live with me, you need a job." And she was very clear about the job. It had to, as she explained it, they had to pay me money for the work that I did. She was very clear that it couldn't be anything that was voluntary or a practicum or more education. There had to be real funds involved.
Show me the money. Show me the money. Show me the money.
There had to be benefits, and there might have been, when I look back on this period of my marriage, Mike, there might have been some trust issues, because she said she also wanted to see a W-2 from the employer to verify that, in fact, I was employed. And when those conditions were met, I would be allowed to move into her house.
That's so romantic.
Yeah, this is a great story, right?
Yeah.
So I did what any self-sufficient, confident, and well-trained young professional would do, Mike.
Exactly.
I called my mom.
I'm like, wait for it. There
I called my mom, and interestingly enough, my mom had a friend who was a psych tech. My mom was a psychiatric nurse for years, and she had a friend that was a psych tech that had just gotten his master's degree and started working at Behavioral Health Response on the crisis line. And she said they're hiring, and I literally drove up instantly, called them, got an interview, drove up, interviewed, and got hired. I started at BHR 3 days after I finished my doctoral internship.
Wow.
Left the Nashville area, packed my stuff up. I was left in Nashville. My wife moved out first into her house. I was left with one of the dogs, one of the cats, a blanket, a TV, and instructions to make sure that the apartment was ready to get our deposit back. And then I started work at the crisis line right away because without working at BHR, I was about to be homeless and divorced, so it seemed like a pretty good option at the time.
Wow.
So that's that's the kind of strategy that goes into my career decisions.
Wow. Well, just like I said, every superhero has an origin story. So there you go. Like that's fascinating.
That's a good that's how I ended up at BHR, and it's kind of one of those for me a God thing because I fell in love with the place immediately, and it turned out to be a perfect fit for me. I love crisis intervention.
What do you love about it?
Well, the thing that was most attractive to me at first was that I don't know about you, but a lot of clinicians, I was horrible with paperwork, right? And when I was in Tennessee, back then they had TennCare, so there was this managed care system and all the forms and the different things we had to fill out to get paid. There was so much paperwork and so much stuff. The cool thing about crisis, now it's quite a bit different now in 2015 than it was when I started in '98. But the cool thing about being on the crisis line was that one, it was exciting, it was fast paced. Two, when at the end of your shift you were done, right? You were finished. Your paperwork was done. Right. Your notes were caught up.
Done.
You walked out. You were finished. So there was the combination of the adrenaline rush and also really being in a connect with people that you wouldn't be able to connect with otherwise. And you walked out and you walked out. You were finished. There was nothing else you needed to worry about other than going home, and I loved that. Now that only lasted for me for a couple of years before I got into management, but that combination. The other thing that I really liked about crisis intervention was there's no conditions on it. That it's kind of like emergency room medicine, right? People can just come in and you're just there. All this other stuff goes out the window. All the other things, all the paperwork that people got to fill out, all that other stuff, all those things that get in the way. When that phone rings and you answer,
you're focused on them.
You're just instantly in the middle of this thing.
Yeah.
And what's really amazing about it is that people are often telling strangers over the phone things they haven't told anybody in their life, right? So there's this safety and this comfort of the anonymity and the ease of access. And I think when I trained my staff, one of the things that we asked about suicide, one of the things I like my folks to take a minute and when someone answers that question, and when they say, yes, I'm having thoughts, keep in mind, you may be the first person that person has ever said that to. It's probably the first time that person's ever said that out loud to another human being. There is an intimacy and a power in that moment when someone who is struggling with thoughts of suicide finally takes that step and trusts another human being enough to say, I'm thinking about suicide. That's an incredible moment. And it's I'm so grateful to all the crisis line folks all over the country that are out there doing it right now while you and I are talking. There's people all over the country on chat, on text, on crisis lines that are the lifeline for folks right now. The only person in the world that they can tell, yeah, I'm thinking about suicide and I don't know what to do. And there's something about that that's very powerful.
A great question from Jimmy here. How do you recharge your battery? Do you get burned out dealing with this level of intensity all the time? Thanks, Jimmy. It's a great question.
That is a really, really good question. And self-care is a huge issue that's getting a lot more attention. As I look back, I'm going to be honest, as a manager, my self-care is a lot worse than it was as a clinician. For whatever reason, I was hardwired for that sort of thing much better. I thrived on it. The only issues that I really had is that early on, and I don't know if for folks that worked in ED, if you've ever rushed through a case, there were some times early on when I rushed through and didn't have the outcomes that I would have liked. And so I learned within the first 6 months of being on the job, my biggest self-care technique was slowing down and just being with the person. And if that meant staying there as long as I had to, but when I left with a clear head, right? So one of the things, my big self-care that I had to learn for myself was get it right the first time, stay with the person, do the best you can, so that when you walked out the door, you really could walk out the door. So when I was a clinician on the phones a lot, and I'm not anymore, but when I was a clinician on the phones, that was never a big deal. The cases that sat with me were all cases where I felt like I rushed. And when I started coaching myself and working myself to slow down and meet them where they were, and not worry about the clock, that wasn't an issue. I think watching the folks that work at BHR now, one of the things that I see is that it's so hard when it's very vulnerable being a crisis clinician, because you're talking to people that often at imminent risk of suicide, and sometimes you have no way of knowing where they are. You can't find them, right? And so there's this tremendous sense of burden that you can feel. And the other thing that is really hard, and I learned this early, your best is your best, and no matter which choice you make when you're working with somebody, you don't know if it's going to work or not.
Right.
You don't know.
Right.
You've got no way to know. So you've got to learn to be comfortable with that ambiguity of outcome. And what I see with new clinicians is that giving up certainty and knowing that you can do the best you can and still have a bad outcome, it can be really draining for folks until they get that sense of, hey, I've got to be comfortable with the choices I make and the interventions I'm doing. And so when I watch folks, one of the things that I've been really working with the clinicians in the call center recently is about how you're always doing the best you can. And you could have done this differently here, but there's no way to know that if you would have chosen X instead of Y, that you would have gotten a better outcome. We don't know that. We really don't. There may be professions, and with medicine, maybe it's often a little more clear cut, but I imagine in emergency rooms and in lots of medical decisions the same way, you often don't know what the best choice was until after the outcome, and even then you're not sure. So helping folks live with that vulnerability and that sense of uncertainty, that can be really draining, and helping them be comfortable with that is a big self-care issue.
Yeah, and April also is chiming in there. Tidy personal life, non-suicide, frivolous hobbies, managing your work time, and insist on what you need to do the job right. And getting a lot of love in the chat room there. So self-care, definitely important.
Self-care is really big, and one of the things we just presented on, I run a Pirinar for NASCOT, and we just talked about clinicians' lived experience and their own therapeutic experiences and how that impacts the care they're delivering. And one of the things that's really interesting is the data. There isn't a lot of data about lived experience with mental illness of providers. And there should be tons of data about this. There's very little. But what we do find is that, in fact, the majority of mental health professionals are experiencing significant levels of depression or anxiety. Much of it's work-related, and a lot of them are not getting help. And so I think more and more you're going to see this self-care and healthcare is going to be an emerging topic that I think is going to get a lot more attention over the next 5 to 10 years.
Another question from Mark. How do you manage the changing landscape? It's probably a policy question, I would think, as far as care and what's happening and all the stuff that's happening as far as from a health policy standpoint.
Yeah, well, from a policy standpoint, I'm not a policy wonk. I think that there's a couple of different things I think of from a policy standpoint. One of the things that we see from a policy standpoint is that for crisis and suicide prevention services, a lot of federal funding is fee-for-service funding, right? A lot of what doctors are doing is fee-for-service funding. Fee-for-service funding is a horrible model for suicide and crisis work, right? And to give you an analogy, imagine that we only paid police officers or fire departments when they responded. Right. That's really one of the big challenges we have with the policy and the funding stream around suicide prevention and crisis services, is that fee-for-service doesn't work really well. And so you've really got to support the infrastructure. You've got to support capacity. You've got to be able to respond 24/7, regardless of how many responses you have. Two, the other thing from a policy standpoint is that the amount of money that we spend on behavioral health, and specifically the amount of money that we spend on suicide prevention, is ridiculous. I mean, it's a fraction of a fraction of a fraction of the scope of the problem. If you look at the suicides, the 10th leading cause of death, 9th in Missouri, the rates going up. but it's not anywhere near to be the 10th most funded area of prevention activity. It's not even in the top. It's not even in the top 100, I don't think. Right. So our funding streams tell us what we value. People who have cancer, we value them. People who have Parkinson's, we value them. People who are fighting diabetes, we value them. People who are fighting behavioral health challenges, people who are fighting thoughts of suicide, our culture doesn't value them. And you can tell that we don't value them because we don't put dollars behind the services to prevent them. And so when we talk about changes, we need to change the culture. I was just doing a presentation recently with some hospital folks, and it's such a clear divide in the medical community. And people can call me out on this. If they disagree, please call me out. But you have your real patients and you have your behavioral health patients. They're complete separate groups. And when they walk into an emergency department, they get treated very, 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 very differently. And interestingly enough, I think that's to the detriment of everybody involved. I think that the medical professionals don't feel good about the job they're doing, and then they compensate for that in really weird ways. And I think that the folks that are getting care, that are fighting some severe behavioral health challenges, are often getting really, really poor care when they reach out for help. And I think a lot of that's based on prejudice and discrimination, and a lot of cultural stuff that makes it really difficult to provide care.
I was scrolling back here. Somebody wanted to know if you're still married.
Yeah, everybody asks that question. I don't get it. Yes, yeah. We just actually celebrated our 21st wedding anniversary.
Wow! Congratulations. Yeah.
When I tell that story, people ask that. I don't get it. People ask that question a lot. Are you still married? Like they're shocked by it.
Well, I mean, how does she put up with you? That's a big question. So I don't know.
Yeah, I get that question a lot too, Mike. I think that yeah, I'll ask her. And get a sense of maybe true love. I don't know.
And I get this question a lot too. So does your wife either know or understand that you are a internet superstar and that you talk into a computer every Sunday night?
No, the kids, they all make fun of me, and my wife's a super huge Twitter. She's got like 19,000 followers at this point on Twitter, so I'm considered a very minor social media celebrity in this family. My son's huge on Instagram. When they're bored, they get on my Twitter feed and make fun of me. So that's no, I'm not kidding. I wish I was making that up, but no. If they're all, sometimes they're just for giggles, they'll get on and they'll see what I'm posting and they'll laugh. So that's my life at home.
Wow.
They ground me. It's grounding, Mike. It's grounding.
What does your wife tweet about? What's her topics?
She's in the funny kid crowd. I don't even know. It's comedic. They give each other trophies. They are very talented, very clever folks. And here's what I'm gonna get on my soapbox. Mental health and medical professionals are some of the worst tweeters on the planet because we don't get the retweet, right? I don't know. We're stingy with the retweet. So when you go into other Twitter networks, they literally retweet each other constantly because they want to expand the message. They want to get the word out. They want other people to see this is funny or this is important. And you'll see tweets getting, hundreds and hundreds and hundreds of retweets. Particularly on the behavioral side, getting retweets is really a challenge. You'll see a few things cycle around that get some attention, but people don't. I don't know what it is. I don't know if they're afraid that if they retweet that the phone's going to explode, or I'm not exactly sure what the reluctance to retweet is, but we got a real problem. They don't quite get it.
I don't know about that. I try to
retweet. You do, but you get it. You're very good with social media, and you put some really good stuff out. So, but if you just look at the general pool, it's not. If the retweets is not great.
All right. Well, hey, that was a fun little interview there. So I don't know if you've talked about some of that stuff or any of that stuff on the air before, because that's kind of cool stuff there, man. Huh. Oh, and you got to do the Letterman thing. You got to do the Letterman thing.
Oh.
Yeah, there you go. Yeah.
But this is when Foreman is monologuing, I'll do this because I don't really have much else to do, and so I'll go into the Letterman mode because I've got I got to at least contribute.
Yeah. Yeah. What happens when she goes into a big monologue and then she just like throws to you and you're just like, and you're like, and you're half paying attention to what she's saying. But how do you get out of that, man?
Sometimes poorly, Mike, would be my answer to that question. I don't handle it. I don't handle it great because she's saying wonderful things. The other thing that Foreman does though is she'll start getting me misty-eyed. So when she starts connecting with a piece of information at an emotional level, and she goes on these eloquent, I don't want to call them rants, but they're kind of ranty. They're eloquent rants. I get a little choked up as well, and so I'm kind of battling a bunch of different things, and then all of a sudden, it's hard to know when she's going to run out of steam. I try to look at the corner of her eyes to see if I can get some clue as to what's going on, but I haven't found a strategy that tells me when exactly the monologue is going to end. So you gotta. It's like riding waves. You just gotta hang tough.
You know that is such a politically correct answer. That's an answer of a valuable sidekick right there. That's what you should say because we're scared of her basically.
And you haven't even been on the pre-show, Mike. I mean,
no, I'm not allowed. I'm not allowed. I've been banned from the pre-show. We'll get into it later.
There's a circle of trust around the pre-show, and I can't say too much for fear of my own personal safety. Right. Yeah. I can say that sometimes the pre-show, if Tony was on, I don't see Tony. He can help us out because Tony's a little braver than I am.
Yes. I wish I could just go into the pre-show and just like not see anything. I would just like go and I get my milk duds and I get my popcorn and my glass of wine and that's all. I don't even need to say anything. You know, just be like, whatever. You know,
we should. The pre-show would be fantastic, and I have to say it's so nice that you're doing this tonight, Mike, because I was definitely in SPSM withdrawal. The first 2 weeks it was nice to have the break, but I started feeling really lost midweek this week.
That's right. So people want to get in. Well, I'll let people in a little bit. So people who don't know me, and Bart, feel free to ask me questions as I kind of describe myself here. So I am a family doc, and I work here in northeastern Ohio. I've been here about 15 years. Born and raised here in northeastern Ohio. My parents are still in this area, and my in-laws are still in this area. So it's nice. Holidays were great for us. Got to see them. It was a good time. I'm a primary care doc, and I am kind of in a semi-rural, semi-suburban type county. We have one psychiatrist in this county. We have 0 psychiatric beds in this county. So it's people like me, primary care, who does a lot of the mental health care in this county, and that's kind of how I was drawn to SPSM and mental health, because I relate to a lot of the topics that you guys talk about. I got to meet April and Tony. I think it's been maybe about 2 years now. We were at a conference together. We were tweeting it out. We were tweeting it out so much that we got in trouble for it. And we've been collaborating since then, doing little projects here and there. And it's been great learning. It's been great for me learning more about the suicide prevention community. I had no idea that you guys have a small community, but it's very vocal. It's very passionate. And there's people who I've never have met who are doing projects that I would have never thought about doing, talking to survivors, telling their story. And it's been great for me as a primary care doc to learn a lot about your community, and taking such a serious topic and trying to find an angle, trying to find a way to make it, I wouldn't say entertaining, but to make it lighter, not to make it so serious. And you guys have really, really done that. And it's been fun for me to kind of watch that and to try to help with that, with the retweets, and to try to get more visibility for the community. And just by, just meeting you, Bart, on a computer screen. And I say this about everybody in social media, when I see him on Twitter or on a video chat, I feel like I know you a little bit. And one of these days we're gonna meet up in person, and we're gonna have to ask April to bail us out of jail. We're gonna have so much fun, and it's been really cool just for me to kind of see all this happen. So I don't know if you have questions for me as far as
I do, because I've been following you on Twitter for a while, and every once in a while, when you're at conferences, you're a great live tweeter. So you're really good at live tweeting conferences, and so even if it's a conference that doesn't necessarily fall in my wheelhouse, that you do a good job, and I get sucked in really quick. How did you get into social media? I mean, when I think of primary care physician and your social media savviness and how much stuff you do on social media, those two don't naturally connect for me. How did that happen?
Yeah, that's a great story. So I started blogging. It'll be 10 years ago this year, if you can believe that. I was sick for a week, and I was driving my wife nuts. And actually, I was drawn a little bit more towards podcasting because, as you noticed, Bart, I have a face for radio, and I've always wanted to kind of be on the radio. So I started listening to podcasts, and then I was like, oh, are there what are these blogs? Because I think it was during some kind of political cycle where they were doing a lot of political blogs, and I'm like, oh, are there any doctors out there who are blogging? And this was 10 years ago. So the culture 10 years ago was for everybody to be anonymous when you're blogging, especially when you're a physician. So they had names like Panda Bear and Grunt Doc. And the cool name that I took was Dr. Anonymous back 10 years ago. So back then, 10 years ago, I blogged about stuff that you should never blog about now. I talked about patients. I talked about attorneys. I talked about insurance companies. It was basically a venting type platform. And then the first 2 years when I started blogging, people started getting in trouble for it. People started getting fired for it. People started figuring out that, hey, this is not a cool thing to do. One of the noted cases at the time was a pediatrician who was blogging about his malpractice case during the trial. So it was a great reading. He was making fun of this person and that person, but they found out during the trial that he was blogging. And in this kind of Perry Mason television moment, they said, "Are you Dr. Flea?" which was his name at the time. He said yes, and then the case was settled. And then anonymous blogging was kind of sending ripples through the area there at the time, and it was huge controversy, as you can imagine. Wow. So I almost quit because I'm like, well, they're going to find out about me because my town doesn't know it. I live in a small town. My hospital didn't know I was writing. My practice didn't know I was writing. My wife didn't know I was writing. But a lot of my readers were like, hey, Dr. A, you have to, you'll figure out a way, we like how you write, we like how you express yourself. So at that point, I kind of shifted to talking about more hot topics, more about health policy, to be more promotional about health, especially when it comes to things that I'm passionate about, especially like immunizations, how immunizations do not cause autism. Flu shots don't cause the flu, a lot of primary care type topics, because I really thought that, medicine, was really behind the 8 ball when it came to vaccines and autism. People like Jenny McCarthy, were on television, and we weren't, as an industry or as a profession, ready for that. So I took more of a proactive approach, in my writing and talking about primary care topics, including mental health. And I talk about now, how we need more funding for a lot of these things, how we need to value the primary care doctor, not only mental health, but primary care physicians as well. We need more funding. We need better funding. And it shouldn't be all those stupid specialists. Well, I love you specialists, but come on, give it up. You know what I'm saying? And then at some point I started experimenting, doing a little bit of video, doing podcasting, doing writing. And then at some point people started asking me to go to conferences and talk about why physicians should use social media. And there's still a lot of physicians who are still hesitant about it. Understandably, they're concerned about liability. They're concerned about patient privacy. They're concerned about getting in trouble. A lot of them want to get paid for it, and it's not there. So there's a lot of hesitancy from it. A lot of people associate social media with their electronic health record, which they hate. So why do you want me to go back on the computer? Because I've been already on doing my charting for 9 hours or whatever. Why do you want me to do that? So it's still a fight when it comes to physicians and social media, especially primary care. But we're getting a little bit better. A lot of my family medicine colleagues, we have a little group that we call ourselves Family Medicine Revolution, FM Revolution on Twitter, and we talk about the value of primary care, the value of a family physician, and we're trying to educate the public on that too. And that's been fun, going to conferences, not only talking about advocacy issues, but I also like, as you've seen there, Bart. I mean, I like talking about clinical issues. If there's a latest drug or medication that's out there, if there's new recommendations about things like obesity or cancer recommendations or that type of thing, I like to educate people about that. Because what I tell docs when I talk to them is, if we as physicians, don't do this for our patients, who's going to do it? We're gonna let people like the attorneys do this, or other advocacy groups who don't like physicians do this. Are we going to let celebrities educate people about health? I don't think so. We need people who are clinicians, who are there at the grassroots, who are doing this all the time, and that's why I feel passionate about social media and medicine. So it's kind of a long answer.
No, it's a great answer, and there's lots of stuff I want to follow up on that. But we got a question for you. This is from Janet Kennedy.
Yeah.
Mike, I know you're very, very committed to social media. Is your practice going to engage more, or are you the social media face of your group practice?
Yeah, that's a great question. So we do have a newer physician who just started working with us, and she had a lot of questions about social media presence. So it's not going to be me. It's probably going to be me and this new physician. The older physicians, the more veteran physicians, that bring up the same hangups as far as no time and patient privacy, and not really understanding the medium, which I understand. If you're not really familiar with it, you're kind of hesitant about it. But it's just overwhelming sometimes just to try to educate people about some of this stuff.
It is, and there's so much in what you said. It's one of the things that I've always kind of gravitated to you. I really see so much of April Foreman in you. You guys were really, really revolutionary and innovative at a time when it was really scary. I mean, you guys have paved the path, so to speak, and made it easier for other folks. And there was times when you guys were out there doing this and really it was going against the grain and probably felt really scary, would be my guess at times. Were there times when you almost gave up?
Oh, yes, absolutely. Absolutely. Every time I would see somebody on Twitter, or even before Twitter, I would see news reports of people who got fired. I've got people who got sued. And I'm like, is this really worth it? Is this really worth it for me to get my voice out there to people who may not understand? Or I knew, everybody knows attorneys, or some attorneys come after physicians and they're just waiting for the shoe to drop, for them to come after you, whether it's a clinical issue or even social media. So there's a lot of ways where a lot of times where I felt like quitting. But then I'm like, well, I got to find a way to get my voice out there to tell the truth about a lot of these medical issues. And so, yeah, I did think about quitting a lot of times.
Wow. What kept you going? I mean, I hear you talking about your need. What was that drove you forward? If you could put your finger on it, what was it that kept you in this and helping folks like me be more active? Because if it wasn't for folks like you in April, I wouldn't be able to do the things that I can do on social media.
I mean, it was easy. It was all the people who sent me feedback. All my followers, or all people who. Even before Twitter and Facebook, they left blog comments. If people remember blog comments for 10 years ago, that was the only way to do this. And I remember when I got some of my first international feedback, I got some emails from people in Europe or in Asia, and they're like, hey, we may have a different political system, but the patient-physician relationship provider relationship is the same here. We want you to keep telling that story, and we like that we like what you're doing. That's a little tip for people now. If you like what you're seeing, give them a thumbs up, give them a shout out. There's one of the things that's really changed the last 10 years is there's a lot more meanness going on there in social media. It's just like, I don't know what it is. I mean, when it first started, there was a nice tight knit group of people. You can have real conversations on Twitter. Now it's just like Twitter's just like a broadcast medium, and you can't really have good conversations on it anymore. And if you really like something that you're seeing, give some good feedback from it, because there's a lot of talented people out there who want to jump into this, who are intimidated by it, who are overwhelmed by it. You just need a little bit of encouragement, especially to newer people. We need a lot more newer people in healthcare and mental health and the suicide prevention community all around the place doing this.
That's so important. It's so important, and really, it's about relationships. And I think one of the things that you're talking about is the connection to folks that were connecting with you and giving you positive feedback, gave you the kind of that oomph to keep doing it when it was painful and scary. And I think that's really important. One of the things that you mentioned was about, we talk when we're on SPSM and we're talking about suicide, we bring in humor and maybe it can be entertaining, or should it be entertaining? And I think this is really important, because I actually think that we've created some really bizarre artificial dichotomies about information. And that, in fact, people are informed through all kinds of entertainment, right? And we really should be entertaining when we're trying to inform. So I'm a big believer that entertainment should be a part of what we're doing. And interestingly enough, when you look at adult learning theory, adults need to be entertained. If it isn't interesting to them, if they aren't enjoying themselves, they don't learn as much. And so, just thinking about it, how many times are people watching sitcoms or shows or comedy shows or movies, and they're picking up some factoid, right, that they then use later in their life? The interesting thing is we don't know how accurate those factoids are, right? There's a lot of things that we've learned from TVs and the movies that don't turn out to be, they're like sort of true, but not really very true. On Curb Your Enthusiasm, they did a funny piece on this about Hodgkin's, right? And he's talking about somebody comes down with a Hodgkin's diagnosis, and Larry David's like, well, is it the good Hodgkin's or the bad Hodgkin's, right? And this is all boils down from a TV episode he'd seen where somebody had Hodgkin's, and it was the kind you lived from, right? And it was really funny because I had a similar experience where I watched a TV show and they were talking about Hodgkin's, and like, well, there's good and there's bad. Well, it turns out Hodgkin's is really scary for everybody, and it's a really, really bad disease. But here in these entertainment settings, people are coming away with what they think is really good information, but it's not. And I think that, in fact, we who are providing important and vital information need to be more entertaining, because we've got to combat the entertainers who are out there doing a really bad job informing people. So that's one of my little pet peeves, is that information should be entertaining, and we should be able to help people learn things, and they should want to engage with us because they enjoy it, right? I think that's vital.
So I guess Tony Wood is unavailable, but I'm sure that both of us will get a little email later critique about the performance tonight. So, all right.
He won't be shy with his critique, I promise. Tony's not shy.
So other questions that came up there, Bart, and if not, then I'm going to open this up here in case people want to chime in on video here and make fun of us.
Yeah, let's see. Yeah, let's do that. Let's see what happens.
All right here. So if you're here and you want to chime in there, April Foreman, you can feel free to try to hit the button. And just take cover. That's all I'm saying. Are you ready, Bart? All right.
Let's do it.
Here
she comes.
Hi.
Oh, April. Yeah. Oh, woo.
We have no video. Yeah. We got no sound. We got no sound. We got no sound.
We got no unsalted mixed.
No
I
sound.
got those.
No sound.
Oh, product plug. She's just
no sound.
Mike. We got no sound, Foreman.
And she recursed already, and we're like, yeah, that's great.
That was awesome. But I love spotting a fellow Costco shopper because I love
That's right.
Costco.
Yeah.
Oh,
No,
she's back, and
no.
no.
Yeah.
What's the sign language for no?
Yeah.
No, it's not. That's not.
Oh.
See, but Mike, people are doing the best they can.
You know,
and I think that
we appreciate the effort.
Have you read any Brene Brown?
Yes.
Have you read any Brene Brown? Oh my God, I love Brene Brown. And I find that I have to, when I'm interacting with foremen, I've got to go to my Brene Brown place a lot. It's almost like kind of like Luke with Yoda. You gotta. There's certain people where you just gotta go Yoda. Sometimes I gotta go Brene.
Yeah. I mean, if anybody else wants to jump in here and say hello and disagree with everything that we've said during this hour, feel free to jump in here. And Jimmy. Let's see. Hopefully this can come through here.
Hey,
Jimmy!
Hey!
Where are you, Jimmy?
Check it out.
I'm out in my wife's studio. So she's got a pottery studio, and I got pushed outside. I didn't want to bother the Netflix movie tonight.
Oh.
Ooh, what are they watching?
I don't know. Some crazy movie.
Well, we just watched Paper Towns. I loved it. My daughter loved it. The wife ragged on it the whole time. So you can't make all the people happy all the time.
So, Jimmy, I appreciate you chiming in. A lot of great feedback in the chat room. Any thoughts on what we've been talking about here tonight there, Jimmy?
Well, I thought, I was putting myself in Bart's position about, where you just have to, at least in primary care, and Mike, you've probably been in the same arena, is that for the first 15 plus years of my career, I did everything: hospital, nursing home, outpatient, and I finally had to trim it back about 5 years ago and went outpatient only. And in so doing, I was able to get some more time. I think I was really, if not burnout, close to burnout at that point. So for me, and what you're saying, Mike, about social media for me has been a good thing in terms of, I think, a way to, it's probably selfishly a form of therapy. But on the other hand, like you, Mike, I try to do some education, try to get my voice out there, especially things that I've found that work in a small primary care office here in rural Montana. So, but does April have sound now?
Say something.
Oh,
Nothing. Nothing. This is the best show ever.
Yeah, she can't. Well, it's probably a good thing that she doesn't have sound because we only have like 30 minutes left, and 25 would be just boom.
Hey, I'm gonna hop off, you guys,
God.
But this was a fantastic show. Great interview.
Right.
Great answers. This was very informative, and I appreciate you guys doing this. But I'm going to hop off so somebody else can get on. And,
Cool.
And hey, Sean, good to see you, Sean.
All right, Sean.
Hey,
Hey, Sean.
Doing good. Did we got
What's
sound?
going on, man?
No.
Yeah,
we can hear you. Yeah, you've been doing this blab thing for a little bit. What's your? I think you've been liking it, haven't you?
Yeah, I really have. What I like about it is every time that I've done it, it's turned into like this interdisciplinary team where you have a family doctor, a psychologist, and a social worker. Or there was one. Yeah, it's been really cool. I think it's just a great way to get people together and share different ideas.
Yeah.
Well, and one of the things that I'm really grooving on, hearing from Jim, hearing from Mike, we really need primary care physicians talking about behavioral health and mental health issues. Because one of the things I've learned over the years is that when law enforcement and when physicians talk about behavioral health, people pay fucking attention. As a psychologist, Sean, you as a social worker, we're supposed to be the experts, but when we start talking, it's just blah, 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 blah. But boy, if a police officer or a physician gets up there and says, this is important, we need to look at this, all of a sudden people are like, oh, hey, this sounds really important. And that's why when folks like Mike are willing to talk about this, and Jim get up and talk about primary care and behavioral health and suicide, it's huge.
Well, I think it's strength in numbers. You know, the more people you have talking about it, and the more different lenses you have, and people saying that it's important, that's when you're going to get results. You know, if people like Mike step up in leadership roles and say, you know, hey, as a family doctor, this is really important. We need to address this. We really need to look at this. And that's when people are going to start to listen too.
Exactly.
Yeah. Oh, and April just posted this stat, and I'm reading an amazing book right now. Craig Bryan and Paul Rudd on suicide, managing suicide in primary care. It's a fascinating book. And April cited the stat: most behavioral health care is already occurring in primary care settings. Right. That's where the bulk. April cited 80%, which sounds right to me. So most primary care physicians are already doing suicide prevention. They just don't realize it a lot of times that they're already doing suicide prevention. When you're helping someone with depression or anxiety in a primary care setting, you are doing a form of suicide prevention. And so I think that, because I've heard some physicians say, well, we don't know if we want to do suicide prevention in a primary care setting. Well, you're already doing it.
You don't have to do suicide prevention or diabetes care.
We have sound.
You can
she's got
choose the
sound.
public health things you need to do, because I know that was part of your medical oath. that medical oath is a multiple choice item.
So, how's it going?
Well, people with behavioral health issues don't count, April. So, come on.
Good news, people
Let's
don't
be real
behave.
here.
Well,
So a little sassy.
what's your beverage there of choice there?
I don't even have coffee right now.
Schweppes. Schweppes like the poor chicks carbonated water. It's kind of like the. It's like the. We'd call that hoosh here.
So this is the official after show.
Schweppes.
So you can feel free to curse as much as you like.
I don't know when I don't feel free to do that, Mike. I'm trying to figure that out.
Oh, I see. Huh.
Is this thing on?
There was a recent study came out showing a relationship between the use of profane words and intelligence. I think smart people fucking cuss more fucking often is what I fucking
You're going
believe.
to be an oozing, pustulant asshole with greasy discharge, and you should, yeah. I did well on the SAT.
Okay, I think that my blab cherry has been perforated at this point.
Let me.
For that, but sometimes your doctors don't choose to treat it.
You're freaking Mike out, April.
I'm just.
Okay, Mike,
let me
ahead.
just hit stop, and then we can continue.